Hello, welcome to FISPGHAN Expert Insight. I am Songpon Getsuwan from Ramathipati Hospital in Bangkok, Thailand. Today, I'm with Professor Huey-Ling Chen from the National Taiwan University. Hello, Professor.
Hi, Songpon. Greetings.
So today, we're going to talk about the recent FISPGHAN position papers on infantile cholestatic jaundice. So what do
Yes.
you think is the most important shift that has been described in these position papers compared to the earlier guidelines?
Yes, one of the most meaningful shifts in the FISPGHAN position paper is the move toward a more comprehensive and globally adaptive diagnostic framework for neonatal cholestasis. The earlier guidelines mainly focus on diagnostic evaluation once cholestasis had been established. And there are three major advances highlighted in this position paper. The first one, this paper strongly emphasized earlier detection of biliary atresia because the time of Kasai portoenterostomy remains the most important factors influencing outcomes. Second, an important advance is the integration of genetic testing into the diagnostic pathway. With the development of next-generation sequencing, genetic testing allows earlier and more precise diagnosis of diseases such as PFIC, Alagille syndrome, and various metabolic liver disorders, which previously could remain undiagnosed for a long time. And third, this precision paper takes a global perspective, acknowledging that diagnostic resources differ between countries and different healthcare systems. Therefore, it encourages institutions to develop a more flexible diagnostic algorithms that combine clinical evaluation, laboratory testing, imaging, and genetic diagnosis. So overall, the major shift is toward earlier detection and precision diagnosis, using modern technologies while maintaining adaptability across healthcare systems.
Well, thank you, Professor. As you have mentioned that the position papers emphasize on early detection strategies, what could be the suitable screening method for infantile cholestatic jaundice?
Okay, early detection is absolutely critical. So this position paper highlights two major universal screening strategies. First one, stool color card screening. And the second one, early direct or conjugated bilirubin measurement, or called fractionated bilirubin measurement. Both methods have been successfully implemented in several countries and have been shown to enable earlier diagnosis, earlier Kasai surgery, which improves native liver survival. The stool color card approach, which was pioneered in East Asia, including Taiwan and Japan, is simple and cost-effective, and it empowers parents and primary care providers to recognize pale or a colic stool early. On the other hand, the direct bilirubin screening measures conjugated bilirubin or direct bilirubin in newborn blood samples shortly after birth. This approach can detect cholestasis even before any clinical symptoms appear. So the key distinction is between universal screening and targeted screening. So in universal screening, you will screen all healthy newborns. And the target screening actually is the ways that we use everywhere today. So universal screening means testing all newborns. So ideally, universal screening is the most effective strategy to detect biliary atresia early. However, implementation is very important and it requires national health policy support and healthcare infrastructure.
Now, despite decades of awareness, delayed Kasai operations in patients with biliary atresia is still a huge problem worldwide. What do you think is the most important things that needed to be done to overcome this problem?
Yes, delayed detection of biliary atresia and delayed Kasai operation is a very important and very urgent issues. So I believe that most important change is building an effective early detection system that connect primary care with specialized centers. So the delayed surgery, we believe, is usually from late recognition and late referral. So first, I will emphasize again, universal newborn screening programs should be implemented wherever possible. Second, education of healthcare providers and parents is crucial. Persistent jaundice beyond 2 weeks of age should always trigger evaluation with fractionated bilirubin testing. So I think it's the job and the role of our society members, experts, to help education for all the healthcare providers and parents. Third, we need clear referral pathways to specialized centers where diagnostic evaluation, including imaging, biopsy, intraoperative cholangiography, can be performed rapidly. So, by strengthening screening system awareness, referral networks, and modern diagnostic modalities, we can significantly reduce delays in diagnosis and improve outcomes. So, the key message of this position paper is that early detection, integrated diagnosis modalities, including genetic tests and global collaborations, are essential to improve outcomes for infants with cholestatic liver diseases.
Thank you, Professor. For those of you who are looking for more information, the FISPGHAN position papers on infantile cholestatic jaundice provide more details on this topic. So please refer to the following link. So
Yes.
Thank you everyone for watching and see you next time.
Thank you. See you.